So today I'm going to be talking about the major research component of my 2024 summer internship, the IFEDD Access to Care project. So just a little bit about me. I'm a nutrition undergraduate student here at Texas A&M. I'm actually graduating in December, and I will be attending Texas State for my master's in human nutrition. So first I wanted to introduce my mentor. Her name is Jessica Setnick. She is a registered dietitian, eating disorder specialist, speaker, speaking coach, researcher, and director of the International Federation of Eating Disorder Dietitians, which was what this research program was done under. And obviously she wears a lot of hats, but I was very lucky to be matched with her in the RD mentorship program. So we've actually been working together on this project since last September. And it was actually just last week that we submitted our research article for this project. So it's very exciting. So just some terms to define before we get started. MNT stands for Medical Nutrition Therapy and is defined as nutrition-based treatment provided by a registered dietitian. ED stands for eating disorder. RD stands for registered dietitian. And MAPIA is short for the Mental Health Parity and Addiction Equity Act, which is where we're going to start our background. So MAPIA was passed in 2008, and it was supposed to ensure parity in coverage, or coverage that is no more restrictive than for mental health/substance abuse benefits as for medical/surgical benefits. So this basically just means that there can't be additional restrictions or requirements to qualify for coverage just because care is for a mental health condition rather than a physical health condition. So an example of a violation of my PIA, this is actually one that I pulled from one of our case studies, would be covering 26 visits with a dietitian for obesity, but only covering 10 for an eating disorder. And although the passage of MPIA was supposed to ensure parity, it is widely known by eating disorder care professionals that coverage for MNT for eating disorder patients is routinely, improperly, and illegally denied. And whether it is intentional or not, these denials are illegal, and it's causing patients to not receive care that they are legally entitled to. When these improper denials happen, it can be an incredibly lengthy and time-consuming really high effort process to appeal them and restore coverage. For patients and their families, the eating disorder diagnosis is already difficult to deal with. They also have the job of securing other types of care for the eating disorder. And they also have normal lives. They have families to take care of, they're working, and they may not have time to go through the appeals process. For dietitians, they are going uncompensated or have delayed compensation for their normal work, but they're also spending additional unpaid hours working on appeals. And because if they do not have this additional time, they may be forced to choose not to accept insurance for payment, which shrinks care networks. And overall, this leads to patients having to pay out of pocket or discontinue care, which can lead to non-recovery of the eating disorder, relapse, hospitalization, ER visits, and death. So what is the Access to Care project? Our goal with this project was to capture the scope and scale of improper denial of insurance coverage for MNT for eating disorder patients, as well as identify significant features or trends. So these are kind of some of the questions that we were looking at. This was a pilot study, so we were just wanting to get an idea of what patients and providers are experiencing so that we can build a more in-depth and comprehensive survey later. So this project was started by Jessica Setnick as well as Domna Antoniadis. She is pictured here. She is a lawyer who very generously offered her legal expertise pro bono to IFEDD's dietitians to help them and their patients with their own disputes and appeals. But she and Jessica wanted to address the problem on a larger scale. So the work that I did on this project prior to the summer was a literature review and creating the data set. So for the literature review, I identified a total of 10 articles that were somewhat related to our topic. These are just some of the search terms there, but search revealed that this area has been relatively unstudied and no attempt has been made to capture this problem in the modern day and post the passage of MAPIA. So for data set creation, a message was sent out to dietitians via the IFEDD listserv. And we initially asked for three things: the name of the insurance company and insurance plan, the name of the employer and the state they're located in, and a narrative description of the problem that they've been having with insurance. And within 72 hours, we collected 172 cases. So these are all of the categories that I went through as I read each of the narratives and plugged in the information for each case. I believe they did end up being slightly different after Jessica went in and did a final review of the data, but this is pretty much what we were looking at: the plan types, the reason for denial process, and the types of interventions, which we'll talk about later. So as we're getting into the data analysis portion, I just wanted to go ahead and introduce Luella Fu and Gabrielle Salamanca. They are data analysts from San Francisco State University, and they were really key to this project. So they used Tableau Public and Google Sheets to create data visualizations and perform simple calculations to identify trends. So before I get into our findings, I just wanted to mention we had a really awesome opportunity to present our preliminary findings to insurance regulators and other related parties from the US government. And these images here are just a chart showing a patient's process of trying to get their denial appealed. And as you can see, it's a very long and ongoing and back and forth process.
So Hope, you only have about another minute and a half, so you'll need to hurry through the findings, please.
Okay. So our findings, violations are widespread throughout the country. They're not limited to a specific state or area of the country. We received cases from 26 of 50 states as well as DC. And then we found that it was an industry-wide problem and not limited to a certain company or group. And there was a total of 56 companies named in our study. So these are the 7 types of interventions that we found that were used in the cases. Some of these things, like a reconsideration request, letters of medical necessity, peer-to-peer review, those are all things that people may not have time to do or are very effort intensive. So the primary outcomes from our cases, in only 7% of cases, they were successful in getting the improper denial reversed and getting their care covered for. In 15% of cases, patients had to pay out of pocket. In 13% of cases, they decided to discontinue care. And in 65% of cases, they went unresolved after months of waiting. So based on our data, the likelihood of getting an improper denial reversed was at most 50%, and that was with having 4 or more interventions. If you only had 3 interventions, there was only a 20% chance of insurance coverage, and if you only had 2, there's only a 16% chance of insurance coverage, which is very low. So just some discussion. These are just some graphics that I made over the summer about the prevalence of eating disorders, and just want to say such systemic illegal denial of care is unacceptable. And when we ignore this problem and allow the patients to get worse, it just causes them to need higher levels of care, which is more undue suffering for them and a higher expense and burden on the American healthcare system. So this just ties into
we're going to have to move on, Hope, so that we can make sure that everybody gets done before 2 hours. So we do appreciate you, and we thank you so much for the research that you presented.